Hello everyone, and welcome to your Electronic Health Records course. Today we will be going over Chapter 6, Financial Management, Insurance, and Billing Factors. Before we get started, let's go over today's learning outcomes. When you finish this chapter, you will be able to explain the need for a claims management process, describe and list the information contained in an encounter form or superbill, take the steps to update a patient's account in Prime Suite, code using ICD-10-CM, PCS, and CPT codes in Prime Suite, understand the links between documentation and code assignment, explain accountable care organizations, describe the information contained in explanation of benefits or a remittance advice, go through the steps of maintaining accounts in Prime Suite, and explain the needs for a compliance plan. Now let's take a look at today's key terms. Starting with abuse, accountable care organization, accounts payable, accounts receivable, adjudication, Affordable Care Act, code linkage, co-insurance, compliance plan, co-payment or co-pay, deductible, evaluation and management, explanation of benefits, fee schedule, fraud, healthcare common procedure coding systems, insurance plan, insurance verification, managed care plan, medical necessity, remittance advice, subscriber, and transactions. Now let's jump right into today's lesson. Claims management, why and how? Let's first start with patient charges. Remember, healthcare facilities have to make money, so patients are charged for the care received. Now, some patients do have their charges written off, and at times it is necessary to write off patient charges or balances on their account. This shows an accounting of the visit and charges, yet the practice would not add those charges into the accounts receivable. Writing off means to adjust the balance accordingly so it reflects no money owed. So stop and think. In what ways can inaccurate charges impact the practice's financial accounts? Well, inaccurate charges impact many aspects of the practice. The charges incurred and the amount of money collected will not be accurate, which means the financial records for the practice will not be right. Even if a patient gets their medical charges written off, it is important that their information is still entered accurately into the system, so there can be an accurate picture of the number of patients seen. Because the financial stability of the office is so important, there has to be a process, or more specifically a written claims management process, to keep everything in order. With claims management, there has to be an efficient and effective system. This includes written financial policies, such as how much is charged per service, and making sure there is a fee schedule. It's important to remember the amount charged for services rendered in physician's office by current procedural terminology or a CPT code. Within claim management, there should be policies for timing of filing claims and making sure it is done in a timely manner. Also, policies on following up on unpaid claims and collection procedures when claims are not paid. So stop and think. Why is it important that financial policies be in writing? Well, let's think about this. When policies are in writing and presented to the patient, the medical office can ensure that there should not be any miscommunications in the future when it comes to the policies. It allows patients to be aware of how the office handles financial matters so they can prepare themselves, and this will result in less confusion. Next, let's discuss the use of practice management. As you are probably already noticing, the use of practice management in the healthcare facility always improves the efficiency of a claims process. It allows for accurate capturing of charges and submits automatic reminders. Practice management software also offers a variety of reporting options and provides automatic follow-up of each account, saving the practice a lot of time. Practice management also aids in the financial aspect of the medical offices, resulting in a less chance of missed charges. missed payments, and payments being processed to the wrong accounts. Remember, each patient is entered only once in the practice. Remember, each patient is entered only once in the practice's database, and each encounter after that, such as office visits, are attached to the master entry. Each encounter has an account attached to it, and the claims process must be fulfilled for each of those accounts. A big positive to PM software is that it helps track claims and payments for each encounter. The patient's account for each visit begins when the appointment is made. It's important that the patient is asked 2 personal identifiers. This ensures that the correct account is pulled up for the appointment and prevents duplication of account creation. Some examples of unique personal identifiers include name, date of birth, and medical record number. Also ask for the expected source of payment. Make sure the patient knows the policies for patients paying out of pocket and verify or update insurance information for patients with insurance coverage. That brings us to our next topic, insurance coverage. There are many different types of plans, but first, let's discuss government plans. There's Medicare, Medicaid, and TRICARE. Medicare is for patients over 65 years old or for those with qualifying disabilities. Medicaid is for patients who qualify as financially indigent. And TRICARE is for military service members and their families. Other plans include private insurance and group insurance types. Indemnity is a contractual agreement in which one party guarantees compensation for actual or potential losses or damages sustained by another party. This is also known as a fee-for-service plan. There's also managed care plans, and these promote quality, cost-effective health care and focuses on monitoring patients, preventative care, and performance measures of providers. With the managed care models, physicians contract with plans to provide care at a predetermined rate. The rate is paid out per member per month in one predetermined payment. Now, verifying insurance and making sure the patient is covered before services is very important. It typically occurs prior to the patient's arrival for the appointment. Someone from the medical office will contact the insurance carrier to receive validation of coverage for the patients. This includes deductible status, which is the amount the patient pays before insurance coverage begins. The co-payment amount, this is a fixed amount due at the time of each visit. The co-insurance, which is the percentage that the carrier pays and the patient pays, and they verify that services provided qualify to be covered by the insurance plan. Next, let's discuss the outpatient flow. This is going to be different from inpatient facilities. It starts out as the patient calling for an appointment, where they will provide information relevant to the visit. Once the patient arrives, they check in at the front desk. A healthcare professional takes the patient's vital signs and begins documentation for the visit. This includes the chief complaint, history of present illness, the medical review, and the health history. The patient is then seen by the care provider, and a diagnosis is rendered and charges are applied to the bill. The patient then checks out, and the claim submission process begins. Now, in a hospital setting, the patient checkout is called discharged. So now we are to the claim submission process, and this starts with the paper encounter form, also known as the superbill. This is used to capture the diagnosis and services or procedures performed. It is in a hard copy on paper and is computer generated by a practice management system. There are many different names for this superbill, and those include encounter form as well as routing slip. Whichever name it is referred to in your facility, that paper is very important and is filled with information that is transferred to the CMS 1500 form, which is an insurance claim form and is used to bill outpatient encounters. The hard copy of the superbill typically includes the following elements: the name and address of the medical practice, the provider's national provider identification number, the patient's name, the patient's chart number, the date and time of the visit, the CPT codes for common procedures performed in that office, the diagnosis narrative as written by the care provider, and the ICD-10 CM codes corresponding to each written diagnosis. Now, super bills generated by practice management systems may still be printed. The identifying information that we just listed is automatically generated. So now, what is medical necessity? That is the fact that there is a medical reason to perform a procedure or service. The documentation must exist in the patient's record to show the signs and symptoms or history to demonstrate that the procedures were medically necessary. Code linkage is another one of today's key terms, and it is used on the insurance claims to show the relationship between a procedure, which is the CPT code, and the diagnosis, which is the ICD-10 code. It's imperative that every procedure links to a diagnosis. For example, a diagnosis of pneumonia could be linked to a procedure code for a chest X-ray to demonstrate that the procedure was medically necessary and appropriate. Next, let's discuss what a copayment, also known as a copay, is. This is the amount due from the patient at the time for the office visit. It typically is a requirement of managed care plans and comes in fixed amounts. For example, if a patient's copay is $25 for office visits, then that is the fixed payment for every office visit. Because copay amounts do not change, they are usually collected at the time of arrival or during checkout. Now, copay is not relevant to inpatient hospital visits, just outpatient services. Now let's stop and think, why is it important that practices collect patient co-payments up front rather than sending bills for them? Well, let's think about this. It is a lot safer for practices to ask for their money beforehand as opposed to billing the customer later. This ensures that the practice gets their money. Next, let's discuss coinsurance. This is a form of cost sharing required by some insurance plans. This is where both the insurance carrier and the patient are responsible for a percentage of the charges. This form of insurance is based on the insurance carrier's allowed charges. For example, Medicare often has an 80-20% coinsurance. This means that the insurance carrier pays 80% of the Medicare. This means that the insurance carrier pays 80% of Medicare's allowed charges and the patient pays 20%. Now, the amounts due are relevant to the charges because they are based off percentages. Often the patient is billed for the remaining balance after the insurance carrier has paid its portion. Now let's take a look at an example of office charges for a patient with 80-20 coinsurance compared to a patient with $25 copay. Now let's take a look at an example of office charges for a patient with 80-20 coinsurance compared to a patient with a $25 copay. For a $50 office charge, the patient with a copay would pay $25 and a person with 80-20 coinsurance would pay $10. For a $100 office charge, a patient with a copay would pay $25 again, while the patient with 80-20 coinsurance will pay $20. Now let's look at more expensive office visits. A $250 office charge would cost a patient with a copay $25, but this time the patient with the 80-20 coinsurance will pay $50. And if we look at a $400 office charge, the person with the copay And if we look at a $400 office charge, the person with a copay will still pay $25, and an 80-20 coinsurance patient would pay $80. Next, let's talk about alerts, a feature the practice management software offers. These alerts can be generated as reminders, for example, if a patient has a copay or to verify that the deductible has been met. A lot of these can be generated based on the patient's insurance plan. This includes the medical insurance contract under which a patient is covered, the extent to which services are covered, and they may also be referred to as the plan. Coding patient encounters. The care providers document patient encounters in their EHR or on a paper chart. This includes any diagnosis assigned to a patient and any procedure or service performed. Now, both the diagnosis and the procedures must be coded. Coding simply means converting the written terms to nationally recognized alphanumeric or numeric coding systems. This ensures that the insurance carriers across the nation are speaking the same language to prevent miscommunication. This is necessary for filing insurance claims and assists with gathering statistics of conditions treated and procedures performed. It also allows for code linkage, which shows the relationship between a procedure performed and supporting diagnosis to show medical necessity. Remember, improper code linkage can result in claim denials. Next, let's discuss ICD-10-CM, ICD-10-PCS, and CPT. ICD-10-CM stands for International Classification of Diseases, 10th Revision, Clinical Modification. It is used to classify diseases and conditions diagnosed in any healthcare setting, whether it be inpatient or outpatient. ICD-10-CM is also used to record cause of death on death certificates. Now, ICD-10-PCS stands for International Classification of Diseases, 10th Revision, Procedural Coding System. It is used more by hospitals to code procedures. And lastly, we have CPT codes. This stands for Current Procedural Terminology. It is used to code procedures in an outpatient setting. Now let's talk about the difference between diagnostic coding and procedure coding. With diagnosis coding, you use the ICD-10-CM manual. It is used in both inpatient and outpatient settings to code diagnosis. Every encounter has at least one ICD-10-CM code. The first listed is the most closely related to the reason for the encounter, or the chief complaint. And lastly, it is used to support rationale for the medical necessity of procedures. Now let's discuss procedural coding. With procedure coding, you use ICD-10-PCS. It is used in inpatient facilities or hospitals to code procedures. Procedure coding also uses CPT coding in outpatient facilities to code procedures. Any service or procedure performed is assigned a code, and the code must be supported by a reasonable diagnosis. Next, let's discuss the Healthcare Common Procedure Coding System, or HCPCS. This is a coding system required by Medicare and Medicaid to document services and procedures. The Healthcare Common Procedure Coding System has two levels. Level 1 is the CPT coding system for procedures and services, while Level 2 is the coding system for equipment, supplies, and transport. HCPCS is also used to code equipment, such as walkers, canes, and hospital beds for home use. It is also used to code supplies, such as bandages, tape, and ostomy supplies, and it's also used to code transport, such as ambulance transportation. When it comes to finances and insurance, and honestly, really anything in the medical office, documentation is necessary. It's important that all services rendered to patients must be documented, whether it's face-to-face time with the care provider, treatment, diagnostic tests, and procedures. Services and procedures cannot be billed to the insurance carrier unless they are shown to be medically necessary. In order to do this, you have to have sufficient documentation to support medical necessity, such as signs and symptoms and history. The code linkage demonstrates the relationship between diagnosis and procedures. Next, let's talk about fraud. Fraud is classified as intentional deception. In healthcare, fraud takes advantage of a patient and insurance company or Medicare or Medicaid. Examples of this can include performing services that are not necessary and coding services that are not actually performed. So stop and think, what are some other examples of healthcare fraud? How can fraud be avoided? Well, let's go over one example of fraud. If a doctor's office knows the insurance company will only cover a specific procedure if the patient is displaying certain symptoms, and that doctor decides to falsify his notes and say the patient is experiencing these symptoms even though they are not, this is an example of fraud. This can be avoided by one, the doctor choosing to be truthful, but also keeping a good documentation of the patient's services, including the face-to-face time with the care provider, treatment, diagnostic tests, and procedures. This will make the doctor being able to falsify his notes more difficult because from the very first encounter of the patient entering in the doctor's office, all of their information has been documented. Next, let's go over the accountable care organizations, starting with the original Medicare program. This was a typical fee-for-service program with some managed care models available. The services rendered are reimbursed as long as they are medically necessary. Next, we have the Affordable Care Act. This was signed into law in 2010. It resulted in improved access to affordable healthcare coverage. It provides protection from abusive practices by healthcare insurance companies, as well as focuses on high-quality coordinated care with patient input. The reimbursement is tied to quality and efficient use of healthcare services and overall patient satisfaction. Next, we have the Accountable Care Organization. This is a reimbursement model where hospitals, physicians, and other healthcare providers form partnerships. All are accountable for the quality of patient care, and the partnerships work together to provide cost effectiveness and efficiency. One of the main things about the Accountable Care Organization is that it focuses on patient satisfaction and is a pay-for-performance model of healthcare reimbursement. So stop and think. How can accountable care organizations benefit patients and providers? Well, since everyone, including the hospitals, physicians, and other healthcare providers, are working together to make sure the patient is getting the best care, that means everyone will be on the same page, and there shouldn't be any communication errors. That not only benefits the patient, but also the healthcare providers as well. Next, let's go over Medicare's 6 ACO models. First, we have the Medicare Shared Savings Program. This transitions current Medicare fee-for-service providers to the ACO model. Next, we have the ACO Investment Model. This is a Medicare Shared Savings Program. ACOs to test prepaid savings in rural and underserved areas. Next, we have the ACO Investment Model. This is for Medicare Shared Savings Program, ACOs, to test prepaid savings in rural and underserved areas. Next, we have the Advanced Payment ACO Model. This is a supplementary incentive model open only to providers in the Shared Savings Program. We have the Comprehensive ESRD Care Initiative. This is designed for beneficiaries who are in end-stage renal disease receiving dialysis. We also have the Next Generation ACO model. This is for ACOs that are experienced in managing care for various populations of patients. And lastly, we have the Pioneer ACO model. And this is for healthcare organizations that are currently experienced in the coordination of care for patients. Now, participation is voluntary, and Medicare patients do not see changes to coverage when it comes to ACO participation. It provides coordinated care between participating hospitals, providers, and ancillary services provided must be able to share information. In order to make this data sharing possible, EHR and interoperable systems make data sharing possible. With ACO, there are approximately 30 quality measures that are monitored relating to the patient's experience or patient satisfaction, care coordination, and patient safety. Now remember, the higher quality of care, the higher the shared earnings by the ACO. This is a model that goes by the better we do, the better we get paid. And structured data by use of codes allows for measurements of quality. Now we have accounts receivable, getting paid. Accounts payable consists of money being paid from the medical practice. For example, supplies, rent, utilities, and payroll. Now we have accounts receivable, and this consists of monies coming into the medical practice. For example, insurance payments and payments made by patients. Next, let's talk about transactions. This consists of posting of charges, payment of claims in the practice management system, and updates to patients' accounts. When it's time for the insurance company to make payments, there are multiple ways to pay them: electronically by check and by automatic deposit into the practice's bank account. Payments may be for more than one patient care, so they are submitted with detailed accounting of claims for which payments are made. Remittance advice. Abbreviated RA, it is a document that accompanies insurance payments. It details the accounting of the claims for which payment is being made by an insurance company. It shows which procedures were paid for, which patients, and shows any claim denials or reduced payments and provides reasons. The EOB, or explanation of benefits, is similar to a remittance advice. This document is sent to the subscriber, the primary person covered by the insurance plan. It explains the charges for services, the amount paid by the insurance company, and the amount that may be owed by the patient. Now let's go over the elements typically included on an RA or EOB: the provider's name, the patient's name, the claim number, the medical record number, the date or dates of service, and the claim status, whether it's open, denied, or paid. It also includes electronic transaction number when applicable, and service detail. This includes the CPT codes billed, the amounts charged for each code, the allowed amount, which is the amount the insurance agreed to pay, the copay paid by the patient, and the adjusted amount. Elements typically included on an RA or EOB also include a recap of charges and payments, such as the total charges and covered charges, the charges not covered or denied, and a glossary of explanation codes. Next, let's go over understanding the claims process and receiving payments. After the patient has completed services or procedures, an insurance claim is completed based on the superbill, also known as the encounter form or routing slip. The provider's documentation and appropriate code linkage to demonstrate medical necessity. The claim is completed and double-checked for accuracy. It is then submitted to and received by the insurance carrier, and then lastly, the claim undergoes the adjudication process. So let's stop and think. Why is accuracy in the claims process so important? Accuracy is very important in the claims process because one wrong code or piece of information can jeopardize the insurance company and being able to cover the claim. That can be the difference in a patient paying a copay of $25 or having to pay hundreds or even thousands of dollars. Next, let's go over adjudication. This is the process of reviewing claims to determine payment. The claims can be paid, denied, or partially paid. These claims undergo the adjudication process once they are received by the insurance carriers. Claim payment is determined by the completeness, accuracy, and code linkage for the claim. Once a determination has been made, the insurance carrier notifies the provider by sending a remittance advice with the payment. With that includes a notification of decisions and any items that need correction or resubmission. The patient receives an explanation of benefits. The practice then posts payments to specific charges in patients' accounts, and the remaining balances are sent to patients or billed to a secondary insurance. Now, let's talk about managing accounts receivable in Prime Suite. The management of patient accounts consists of charged patients, tracking accounts receivable. Management of patient accounts requires setting up parameters of each insurance carrier and their plans. These plans can differ by co-payments and co-insurance requirements, as well as deductibles, extent of coverage, and rules of filing of claims. Libraries and databases are used in practice management systems to perform functions within the different applications. Some of those include the Insurance Company Library, which consists of all insurance and individual plans represented by the patients in the practice. ICD-10-CM, CPT, and HCPCS Level 2 code tables. These must be maintained annually to account for charges. A fee schedule listed by CPT code and includes charges for each service. Reports such as aging reports, like the length of a time claims have been unpaid, And lastly, alerts. These are reminders to the office staff related to billing functions such as copay alerts, write-offs, and overdue balances. Next, let's go over using practice management software. PM accomplishes filing, follow-up, and collection of claims. It allows electronic remittance of claims and electronic receipt of payment from insurance carriers. Healthcare professionals can see updates on claims at any point in the process. With using PM software, the collection procedures are streamlined. Reports of accounts ready for collections are sent electronically, and the office can see the status of the account, which results in greater billing accuracy and less chance of lost charges and revenue. Next, let's talk EM codes. These are CPT codes used to capture the face-to-face time between a patient and the care provider. It considers the extent of history, extent of physical exam, and medical decision-making required. It is generated based on documentation made by the care provider and is dependent on whether the patient is new or established. If you are a new patient, you are not seen by any provider in the practice within the last 3 years. If you are an established patient, you are seen by any provider in the practice within the last 3 years. And lastly, it reflects the professional services rendered to the patient. Next, let's go over the steps of the revenue cycle with medical documentation. We first have step 1, pre-register patients. Step 2, establish financial responsibility. Step 3, check in patients. Step 4, review coding compliance. Step 5, review billing compliance. Step 6, check out patients. Step 7, prepare and transmit claims. Step 8, monitor payer adjudication. Step 9, generate patient statements. And lastly, step 10, follow-up payments and collections. Our last topic of today is compliance, and these are the rules and regulations. Insurance plans have rules and regulations related to coding, billing, and collection of healthcare claims. If you are intentionally not following rules and regulations, this constitutes as fraud and abuse. The consequences to fraud and abuse include monetary fines and sanctions from insurance plans, and it reduces the number of patients a provider can see and impacts income. Now let's go over a compliance plan. It is a formal written document that describes how the hospital or physician's practice ensures adherence to rules, regulations, and standards. A compliance plan defends the healthcare facility in the event that the Office of the Inspector General investigates suspected cases of fraud or abuse. These facilities should be able to demonstrate that all healthcare personnel follow their compliance plans. Lastly, let's discuss the compliance plan requirements. These requirements include conducting audits and monitoring work performed by the office staff, developing and implementing standards of practice that are uniformly and consistently applied, appointing of a compliance officer, training new staff immediately after hire, and providing ongoing training to all staff, fixing any problems that are found, and performing process improvement. It also consists of encouraging staff to bring compliance issues to the office administration and enforcing the office's policies and not making exceptions. Having, following, and referencing and practice written policies, procedures, and compliance ensures the best outcome for fiscal success and in the events of investigation. That completes today's lesson. If you have any questions, feel free to reach out to your instructor.